Good afternoon and evening. I'm Dr. Dugmajian. It's January 24, 2023. It's now just after 6:30 p.m. It's our sixth case of the day. This is a Duke laser disc repair, left side, L4-5, L5-S1. We're gaining access to L5-S1. And that will be our first successful placement of the needle. Now, the L4-5 is interesting. He's got a synovial cyst, which we're not treating, and he has a disc injury as well, a herniated disc at L4-5. So we talked about the synovial cyst before surgery, and I said, listen, I think your problem is mostly the disc. I can't really treat the synovial cyst from an endoscopic standpoint, transforaminal, because it's too medial to the facet and too anterior, Sean. But I'll do my best. If I can get some of it while I'm in there, I'll get it, Sean. But I didn't expect to get any. I'm not expecting to get any, but I'm going to do my damn best to try to pop that cyst when I'm in there. All right. AP. So I'm low in the foramen. Patient's doing well. We're going to be ready for him to give us a response in just a moment. Okay, beautiful, perfect. What is a synovial cyst? It's a cyst that comes off of the facet joint. Okay, and I'm going to try my best to see if I can get that cyst and rupture it. That way it'll give him some relief.
Thank you.
Are you comfy?
Can you open your eyes, honey? Are you comfortable?
We've lost one drop of blood.
My friend, can you open your eyes for me?
Now, how long has he had back pain?
How long have you had back pain for? Can you tell us? How long?
Never before that?
Can you tell us?
Like a motorcycle injury at age 20 that the pain has contributed to it, but the pain
Jesus, he needs
bad stuff is 3 months,
Yeah. So basically, we have two discs. Thanks. L5-S1 and L4-5. These are the two discs we're fixing. Through a left approach. We're going to do it through a 7mm incision. Can you guys see that right there? That's a 7mm incision. It's literally 1/4 inch. Okay. And I'm waiting for him to wake up a little bit. Now, where did he travel to us from?
California, Sacramento.
Can I ask you some questions, okay?
This patient is from California. He flew into Florida for this surgery to be done. He found us online. What's his chiropractor referred him, which is incredible, and hopefully his chiropractor is watching. Thanks for pointing that out. I remember he mentioned that to me. His chiropractor told him there's only one surgeon in the United States I would let operate on me, and I guess he mentioned my name, so here he is. And we're going to get him taken care of. Doctor, chiropractor, whoever referred, if you're watching, everything's going fantastic. We've accessed the two discs, transforaminal. It went without a hitch. We're just waiting for our patient to wake up a little more. I'm going to try to nail that synovial cyst. Now, Jordan, show the audience on that lateral x-ray. Henry, go back to that x-ray view. Show us where the synovial cyst is. Back. There. Now, see the facet joint? Show us the facet joint. That's the facet joint. And the cyst comes off that joint right back, to the right, there. It's literally at the tip of the arrow. Can I get it? I'm going to try.
He's awake.
Perfect. Are you comfortable?
Are you comfortable, my friend? Yes or no? Yes. He said yes.
How long have you had back pain for? How many years? When did it start? When was the first time?
Remember what? How many years ago?
How many years have you had back pain?
What's that? Say it again. 8 years, he estimated.
8 years. All right, very good. Are you comfortable? Are you comfy?
Yes.
All right. Any back pain right now? What's he saying? I
What'd you
can't hear.
say?
Any back pain right now?
Yes or no?
Reliable? How bad is that on a scale of 1 to 10?
1 to 10. Where's your pain? 1 to 10.
Show us the tear, Jordan.
He said a 6.
That's the highest, is a 6?
Yes.
He's moaning and groaning. Is that where you typically get back pain? It sounded like it was more than a 6. He's going, ah.
8.
All right, he's tough. All right. I'd hate to see what a 10 is when I tested it, and he's going to not remember any of this, which is good, but he can watch it on the video. He's going, ah, under the covers, right? And I'm like, how bad is that 6? Like, for me, a 6 is, you know, when I've had some bad food and my stomach's upset, that's a 6, right? But I don't go, ah! I can tell you right now, my opinion, that was pretty painful for him. Yeah. So it's concordant because he's had pain there. That's where his daily back pain is. Is that better?
Is your pain better, sir? Yes or no? Better?
Did it go away? All right. How bad is that on a scale of 1 to 10?
10.
10, finally. Some honesty, right? Some honesty. Is that where you typically get back pain? Great news, folks. This is beautiful. Both discs are the typical cause of his back pain. We call that concordant. That's why I wrote a C. You get to go to sleep, sir. When you wake up, we'll be done with your surgery. And I think, are you flying back to California tomorrow? Tomorrow night? All right. So get that, folks. This is outpatient surgery. We're going to be done here in 30 minutes. And he's going to be flying back to California tomorrow. Just let it go to the front and that's fine.
Good, right?
Yep, leave it there and just hold it and take out the needle. All right, great. So this is our last surgery of the day. Patient's from California, referred by his chiropractor. So far, everything is going beautifully for him. And he's going to go back to California tomorrow, folks. That's how minimally invasive the surgery is. He's not staying here overnight. He's going to actually go back to his hotel tonight after the surgery. Shot? You're doing great. So both discs were causing his back pain, the bottom one and the 4-5. As a matter of fact, if you look at his MRI at the bottom corner there, it looks like the bottom disc is the worst one. But in reality, it turns out the 4-5 was even more painful. It was a 10 out of 10. So it just proves, folks, you cannot look at the MRI scan to tell you where pain comes from, because you will be wrong 9 out of 10 times. You must examine the patient. The patient will tell you where their pain comes from. You just have to make sense of it through experience and knowledge. And that's what we do at Duke Spine. So far, so good. His chiropractor referred him from California. I think he's going to be very happy with these results. When you have 8 out of 10 and 10 out of 10 pain in your back from the disc that we're about to fix, you know that the result is going to be good. We're good. It is a little tight, but it's fine. You know, prevents the, cold welding. So now we're going to put the tube in, and I'm sorry I don't spend a little more time showing you the tubes and everything, but this tube is 7 millimeters wide. It is a special tube that the whole surgery will be done through this little tube. Okay? We call it an endoscopic tube or a tubular retractor. That's it. I'm going to show it to you in just a minute here. And there it is in all of its glory. You guys see it, Henry?
Yes, we do.
All right. So, beautiful. This whole surgery is done through a metal straw, basically. It's not really a metal straw. If it is, it's the most expensive metal straw I've ever bought. But we call it the McDonald's shake straw. Not because we're being sponsored by McDonald's, but just because it reminds me as a kid when I used to go to McDonald's and buy a shake. Well, my parents bought a shake, but the straw was like that thick. It was a thick straw, right? The shake straw. And of course I could say soda, but sodas are kind of boring. Shakes are more interesting, so we'll just say a shake straw. Anyway, he's here with his family member from California, Northern California. I believe, is it Sacramento? Yeah. And I was there's the herniation. I was having a nice talk with him because I'm also from California originally, but Southern California. He's from Northern California. And I was telling him I'm actually originally from Thousand Oaks, California. That's good, thanks. That's good, thanks. Well, San Diego, of course, was my stomping grounds. I went to UC San Diego undergrad and La Jolla, and I'm telling you, beautiful. Absolutely beautiful campus. My God, those days, so sad. You know, I miss those days of college. As a matter of fact, I reconnected with one of my college roommates just a few weeks ago. He's a urologist in Los Angeles, Danny Cosgrove, Dr. Cosgrove. And anyway, we were roommates at UCSD, know each other very well. Danny was a crazy man. I was very surprised to find out he ended up in medical school and following his dad's footsteps as a pecker checker. Right? There's the herniation right there. So all the back pain is coming from this tiny little area right here in the back of the disc. We're going to clean it up with the laser, and then the pain's going to be gone. Any questions from our audience?
No current questions.
All right, so folks, if you're watching, you're in a weird time zone. But no, seriously, if you're watching, we're going to do this surgery in about 30 minutes, then we're going to wrap it up. We've all been very busy. Everyone's tired. You know, it's the end of the day. So we're not going to do the usual question and answer at the end of surgery. We'll do it right now. If you have questions, this is the time. And I appreciate you all being here watching. So far, everything is going really well for this young man. Let's go ahead and run our video on how does a herniated disc cause back pain? What is it about the herniation that causes so much pain? You're going to see the answer is inflammation. Inflammation right here where I'm cleaning. It's this area right here where the tear is that has so much inflammation. You see there's a little bit of bleeding. The bleeding is there because you see the pink tissue? That's all inflammatory tissue. Let's go ahead and run that video while we finish up this disc.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We're just talking about wine coolers from the college days. We got talking about UC San Diego College. It reminds me of parties, fraternity parties, and sorority parties, and wine coolers.
I went to FAU, find another university.
FAU, find another university. That's so funny. Yeah. All right. Well, we do have a question on the board, so let's go ahead and take that question.
These two questions come from Miran on Facebook.
Miran, hello.
And the first question is, hello from the UK.
Wonderful.
How do you control the instruments around the nerves to avoid nerve damage?
Yeah, a great question. How do you control your instruments around the nerves to avoid nerve damage? Great question. So we are operating in the back of the disc where there are very important nerves. And these aren't just little nerves. These are the nerves that go down your leg. And they control your movement of your muscles in your leg. They control the movement of your foot. And one of them is, if you look at this and think about the laser is at 12 o'clock right here. You guys see the laser at 12? 9 o'clock, there's a nerve root, the L5 nerve root. And at 12 o'clock, there's the S1 nerve root. So we are literally millimeters from those nerves. How do you control your instruments from damaging them? Well, number one, you see how they're protected by this metal tube? The tube is holding those nerves away from my instruments, protecting the nerves from me and my instruments. So the retractor, we call it a retractor, and that's how surgeons protect things, as we retract important things and move them out of the way so they don't get damaged by our surgery. So the tubular retractor is the key. That's number one. Number two, when I was placing the needle earlier, remember, I had the patient awake. So he's going to tell me if I get too close to any of those important nerves. He's going to say to me, hey, it hurts. And so then I'm going to move my tool to a different position. Specifically the needle. It's the spinal needle. Remember in the beginning I placed that spinal needle? Well, that spinal needle is everything. That's the most important maneuver in the surgery. Once you place the spinal needle properly, which I do in the very beginning with the use of the X-ray machine, once you do that, then the risk to injuring nerves is almost zero. Okay? So, two things. Placing the needle properly, and number two, having this tubular retractor here to retract the tissues away, the nerves away, so that they don't get hurt. That's how we protect the nerves. But, you know, the reality is, folks, neurosurgeons like me, we're trained to not hurt the nerves. Our job is to protect nerves. So I make it look easy. I'm not just some yo-yo. I'm a neurosurgeon, a brain surgeon, brain and spine surgeon. So I know I make it look easy, but the reality is I have a lot of training to avoid injuring things. And a good neurosurgeon doesn't injure the nerves when they do surgery. Okay? And just so you know, a lot of people have nerves that are already injured when they come to us. Our job is to try to prevent their injuries from getting worse over time. All right.
We have another question.
Yes.
This also comes from Marin, once more on Facebook.
Hi, Marin.
And they asked, is the pink tissue inflamed part of the cartilage? Is it vascularized? I'm just wondering why the different color.
Yes, the pink tissue is vascular. It's granulation tissue. It's blood vessels. So that's the inflammatory tissue we talk about in the video. That is, well, that pink tissue there are just veins, right? Those are epidural veins, part of Batson's plexus, okay? But there's a lot of times pink tissue that's the granulation tissue from chronic inflammation. If you look at what granulation tissue is, it's young inflammatory tissue, it's early scar tissue. It's basically blood vessels, nerves, they come to the area where there's inflammation. And their job is to clean out the debris and to build new tissue. A lot of times granulation tissue contains stem cells, and the stem cells rebuild that area, right? They create new tissues. And so they're going to repair the annulus, for example. So all that granulation tissue you see is primarily there to try to repair the back of the disc, but it's just not working because the nuclear material from the center has squeezed into that area and it's blocking your body from healing. It literally prevents the healing from happening. And that's what the Duke laser disc repair does. It removes that blue, see the blue thing? That is herniation. And as long as that blue is there, this thing will never heal, okay? So what I do is I go in there with a laser and a grabber and I remove it. And by doing that, it's going to let this disc now heal. That's the debridement, annular debridement. That's what 95% of the surgery is, annular debridement. Laser, laser. And that's what makes it unique, is that there's no other surgery in the world that does an annular debridement. Sure, there's endoscopic surgery. Sure, there are discectomies, but there's no annular debridements besides the Duke laser disc repair. We're the first and the only surgery in the world that does an annular debridement, because we discovered it here. Great question. All right, let's run the video that shows how the Duke laser disc repair actually works. What does it do? That's it.
Play sound, please. Thank you.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. And we have just finished the L4-S1 disc. Surprised that that it went so quickly and easily. And we know that the L4-S1 was causing back pain because when we tested it with the discogram, he had 8 out of 10 pain from there. Now we're moving on to L4-5, the second disc we're supposed to fix. So far, everything is going well for the patient. He's stable. Let's have a little more num-num for Dr. Berndes. All right, any questions from our audience after watching that video on how this surgery actually fixes discs that are herniated or bulging that cause pain? All right, I could feel I almost feel the synovial cyst there.
No current question.
Shot? All right. So here we are at 4-5, and surprisingly, the 4-5 disc, if you look at the MRI, it doesn't look that bad. But that 4-5 was even more painful than the 5-1. So it just goes to show, once again, you cannot rely on shot MRIs to tell you where pain comes from, because they won't tell you. They won't tell you at all. You have to rely on experience and knowledge, knowing that disc injuries of any type, no matter how small they are, can actually be painful. And of course, the most important test for where the pain is coming from is asking the patient. In other words, the patient will tell you where the pain comes from if you ask them properly. You have to ask them a certain way. If you're not careful, you won't get the information you need. The way I do it for my patients, they all know this, is I tell them to put their fingertip on the worst pain. That's it. Where do you get the worst pain? Okay? And they get to only pick one spot. One spot. And you wouldn't believe it. Every single time. They literally will put their finger where the bad disc is that's causing their pain on exam. And I know where those bad discs are because I've been in 1,000 backs. I've seen the spine, I've seen the disc. Go watch my fusion surgeries and you'll see what I mean. When you've done as much open surgery as I have, you've seen it all. And so I use my knowledge of doing open back surgery to know where the discs are, and I put that together with the MRI findings and what the patient's showing me on exam. And with that information, I can identify the source of the pain. It's really not hard. We do it all the time now, and very, very accurate. As a matter of fact, we're getting ready to publish a paper. Actually, we're in the process of collecting data from our patients' charts on the causes of back pain. And we're going to break it down, and we're going to publish that data. And it's literally going to list all the causes of back pain and their frequency in our population of patients here in Florida. Well, which actually includes patients from all over the country, all over the world. So we're going to have a very nice paper to publish talking about where does back pain come from, the frequency of each different cause. The L4-5 disc, the L5-S1 disc, the L3-4 disc, the L5-S1 facet joint, the L4-5 facet joint, the L3-4 facet joint. We're literally going to break down all the causes and ascribe a frequency and an order to those causes. And it's going to be the first paper of its kind. The first time anyone in the world has ever done that. Everyone says back pain is non-specific. Well, we disagree. It is specific. It comes from a specific cause. And we're going to publish those causes and their frequencies so that everybody could see it and know, you know, when they come in, okay, I've got pain around the L5-S1. Well, in my lower back, what's the likelihood it's the L4-5 disc? 30%. What's the likelihood it's the L5-S1 disc? 25%. Whatever those percentages are, I don't know them because we haven't collected the data yet. We're still in the process of doing that. But once we review a few thousand charts and we have a few thousand patients, we're going to be able to publish what the frequency of those causes of back pain is. We're doing the same for neck. And then people can actually almost, I wouldn't say this, diagnose themselves, but certainly do a better job than their doctors do. What's the issue? What is it? What? Your puppy is getting hungry? Oh. Jeez. No. Next time bring your puppy here. What kind of puppy you have? Puppy? That's not a puppy. 7 years old, that's not a puppy anymore. Huh? I love German Shepherd, don't get me wrong. My favorite is probably German Shepherd for guard dog. They're so intelligent. But All right, so those of you watching, this blue stuff is the herniation. It's bad. It shouldn't be here. We don't want it here. And by the way, the fact that it stains blue means it's abnormal. It's damaged. There's the tear. You guys see the tear? The blue is literally showing you where the tear is. The white is annulus, and this is the herniation right here, stuck in the tear. This is why the tear never heals, because it's got this blue stuff in here. Once I clean that out, then it can heal. This is all scar tissue right here. The annulus is scarred. You see that? Thick scar with calcium, the golden stuff. All of this is abnormal tissue causing his back pain. I know it gets into a lot of technical detail, but all you need to remember is this is the cause of the back pain. This is where it's coming from. It's vascularized, it's inflamed, and it's the inflammation within this tear that's the cause of the back pain and leg pain.
We have a question.
Yes.
This comes from Miran once more on Facebook.
Hello, Miran.
They said, thanks for answering my questions. What is the maximum disc treatment one can have in one go? I have 4 cervical, 2 lumbar, and 1 on the thorax, the least problematic.
All right, all right. So thank you for asking. What's the most disc treatment we could do in one sitting? We don't do cervical and lumbar ever because they're 2 very, very different parts of the spine. They require completely different positioning, approach. We would always break those up into 2 days. So we would do your cervical on a Tuesday, your lumbar on Thursday, or vice versa, okay? I prefer to do cervical first, right, Dr. Berndes? Yeah, lumbar second. So you can have your cervical done on one day, and you can have your thoracic and lumbar done on a second day. We can do 5 discs at a time. So 5 lumbar / thoracic, as long as it's not bilateral. So it has to be unilateral, or it has to be, if you do bilateral, it means both sides, it has to be count as 2. The best thing to do, if you're thinking about getting endoscopic surgery like this, send us your MRI and set up a virtual consultation with me, where I can review your MRI, figure out what's wrong through a Zoom call where I'll examine you, talk to you, and then I'm going to tell you exactly what we need to do to fix your pain. Okay? And then you can decide what you want to do after that. Henry, why don't you put the link
Already did.
on there, and if somebody was interested in getting a virtual consultation, they can.
Okay.
All right, so far so good. Everything is going well. We're just about done. I've got 5 minutes left, doctor. I am going to try to go for this sebaceous, the synovial cyst. Keep saying sebaceous, but it's a, sebaceous cyst in the spine? Yeah, that would be bad. I used to take sebaceous cysts out. When I was a resident, we would, we had a surgery attending who said, if you can take the cyst out without popping it, then you would get a bag of popcorn. Okay? So, yeah, right? He was funny. A bag of popcorn. Of course, the popcorn itself looks like a sebaceous cyst. Just what you want to eat. But I did it anyway. And of course, I took it out without popping it. But it was painstaking. That was my general surgery attending at the VA in Lakeland, Florida. They come back because they're not being fixed. No, they're just draining the pus, treating with antibiotics, but then they're not taking the sac out. Huh? Doesn't matter. General surgeons don't take that stuff seriously. They're not going to do their best for a sebaceous cyst. That's like a medical student case, you know? It's below them, supposedly. Huh? The axillary? Yeah. All right, we're just about done with this disc here. And honestly, this is a lot worse than the MRI showed. When you look at the L4-5 disc on the MRI, it doesn't look that bad, folks. Most surgeons wouldn't even treat it. But his pain localized to that part of his back. So I knew the L4-5 was a problem because that's what the patient showed me. If I had just looked at the MRI, I would have left it alone. I would not have treated L4-5. But guess what? L4-5 was 10 out of 10 pain. It was actually the more painful of the two discs, right? So had we left it alone, this poor patient would still be in pain. But surgeons do that all the time. They only use the MRI as the guide for where they should do surgery. And that's a problem. That's going to leave a lot of patients still in pain. So it's important that you get a good doctor who makes the right diagnosis and does the right treatment the first time, so you don't have to keep coming back getting more surgery. Look at all this herniation. Shocking compared to what you see on the MRI. You don't see this on the MRI. It's not that bad. Would the cysts make the MRI herniation? Not, no, that won't. No. Nope. No, the cyst and the disc have nothing to do with each other. And they're completely separate issues. And they don't look anywhere near each other to me on the MRI. 5 minutes. Just trying to finish this up. You can see the epidural space. The cyst will be in there if I can find it. But I want to finish cleaning this up. Those are annular, posterior annular fibers are starting to transition from annulus into what's called the posterior longitudinal ligament, which is a type of ligament that runs behind the disc. And you can see that transition right through there. Herniation has responded nicely to the laser and vaporized, broken up, eliminated. This is the lateral part right there. Happy. Looks good, looks healthy. I've just got to finish the medial part up, which is towards the spine, towards the middle of the spine. All right. I'm going to see if I can see that cyst. You don't expect to. I told this patient, don't expect me to fix a cyst, but if I can, I'll try and remove it or pop it as much as I can. But we agreed we're not going to expect to be cured of the cyst. We're going to focus on the disc. Cyst surgery, by the way, requires a laminectomy usually. You got to get in and do a laminectomy. Laminectomy is very destructive, very damaging. It's a huge tear, huh? Huge. All right, let's see what we can see. How is my last patient? Doing good? He was a bit sleepy, huh?
Yeah.
Is he more awake? Ready to go?
He was waking up when I went out there to grab ID fluid, yeah.
How long ago was that?
Lots of clean living.
Yeah.
Yeah, well, we like that, right? I remember when I had my sinus surgery, they were like, all right, time to go. I was the last surgery of the day, and the nurses just wanted to go home. And I was like groggy, and I'm like, what? Really? I just need a few more minutes. They're like, get out of here. You're a doctor. You don't need to stick around here. Don't you have people that can take care of you at home? Guys. Well, grabber, this is it. I got 1 minute left. I don't see the cyst. And I'm not going to go digging around for it in there. So.
The canister is full. Can you check, Jordan, please? It's not sucking. Yep.
Thanks. All right, laser. This should be it. We're underneath the nerve root, gotten the herniation out. This should, oh yeah, this should give him a lot more room. That's the last of the herniation right there. I'm happy with that. That bleeding, folks, is coming from what are called epidural veins. They are in the epidural space, which means we are done with the herniation. And it went very well. Very pleased. Everything else looks clean and good. That should buy him a lot of room. Okay? All right, I'm done. I'm going to just give 30 seconds here. Any more questions? Because we're going to wrap this up. We're not going to do our usual Q&A. Everybody wants to go home. Had a long day, so if you have any questions, ask them now.
So far, no current questions.
All right, great. That's it.
Lights on, please. Thank you.
Looking good. All done. Thanks for joining us today. We'll be back again on next week. I have a meeting to go to this Thursday and Friday. We're going to be presenting our research, our data, our results of our surgeries on Duke laser disc repair to the Southern Neurosurgery Society. They've accepted 2 papers for peer review publication and presentation at the national meeting.
Stop off, please. Thank you.
Yeah. So one of them is thoracic Duke laser disc repair for thoracic herniations. We had a 99% elimination of pain, thoracic pain, and a 96% elimination of radicular pain, pain radiating around the ribs from the Duke laser disc repair. No complications. And then we have another paper that was accepted, ACDF versus Duke laser disc repair cervical. ACDF had 7.5 times more narcotic opioid use than a Duke laser disc repair. So much more risky. Now we don't do any opioids for Duke laser disc repair, so it's going to be none versus ridiculous amounts. Yeah. Everybody, great job. Way to power through, Luis. Great job. Way to make it happen. Everyone, Dr. Burndes. Can you guys see the incision?
Yes, we can.
Tiny. All right, have a good night. We're going to end the broadcast.